I don't think you need to introduce anybody. Good morning, folks. This is the panel on patient rights, limiting patient rights of access to personal health data. I think it's really a nice follow-on to the previous keynote. And the panel is structured to have again, a little bit the same theme that we had yesterday, where we have a component from the patient side that includes technology, and then going up the list, up the chain of where technology lives and data is used. Once that data is generated. So this is not going to be a long introduction. This is it. The panelists are going to introduce themselves as part of a very short introduction. I will ask 2 questions to start with, and then we will open up for discussion. So Hugo, please start.
Hi, so I'm Hugo Campos. I live in California, and I'm a patient with a cardiac implanted device. I have hypertrophic cardiomyopathy, and I'm at risk of sudden death, so I have an implantable defibrillator. And I'm also a caregiver to an elderly parent who lives with me, 85 years old, who has congestive heart failure. So I'm often in many portals. But a point that is kind of interesting that I would like you to know is that the device that I have, the implantable defibrillator, nowadays it's standard of care for these devices to be remotely monitored by the clinician via the manufacturer. The manufacturer is a business associate of the provider. The provider then collects this data. The manufacturer collects this data wirelessly, and typically while the patient sleeps, and quite often with the consent, but without the knowledge of the patient that a transmission has been made. And the data is not made available to the patient, which has been an irritant to me for the past 7 years. As someone who wants to be engaged in my health and who wishes to have access to this information and be able to freely collect it and share it, I am prevented from doing that. HIPAA doesn't help me. The data does not live with my provider. It's in the possession of the manufacturer of the device. I had something else to say. So I think what's important too is, like, there's been a lot of talk about engagement, and what really is important to me individually is this ability to care for myself, and it really is what I'm after is autonomy, and there's no way to have any level of autonomy without access to information. And I'll leave it at that.
Mark is speaking as a patient. He also has a much broader role, but he'll introduce what it is.
Yeah, I think I'm a fake patient. I've only been to the doctor, I think, once in the last couple of years. Yeah, I actually wear many hats, I suppose. I started Health Camp 7 or 8 years ago, really to try and bring patients to the table and break down the silos in healthcare. That got me involved in Blue Button, which is the ability to basically download your health data. So, 800,000 CMS beneficiaries have done that. 1 million vets have done that at the VA. And I have also I'm co-founder of Media, which is a consumer-mediated health information exchange. So think of it as a universal health record where you control who you share with, what you share, and for how long you share. And the culmination of that journey has actually put me as, I suppose, the government official on the table, and I'm not speaking for the government here. I'm currently entrepreneur in residence at CMS, so I'm on a short-term assignment basically to rebuild the next version of Blue Button for CMS. They first put it up in 2010. It's a simple text file download, and what we're trying to do is build a data API, so data service, a REST API, that allows you as a beneficiary to connect your data with the applications and services that you trust.
Great. And so next we have Randy Farmer, who is another kind of health information exchange and on our way to up the chain.
Thank you very much, Adrian. I'm the Chief Operating Officer for the Delaware Health Information Network. DIN was the first statewide health information exchange to launch in the country back in May 2007. So while Delaware is the second largest state in the country, it's pretty robust in terms of HIEs. We commonly rank in the top 5, top 10 categories in terms of volume for like number of medical deliveries made through our system, number of unique patients. We have 2.1 million. Delaware's population is 900,000, so we have patients in our system represented from all 50 states. We have one of the largest hospital systems on the East Coast with Christiana Care as really one of our anchor health care systems. So it's a pretty robust health information exchange, and that gives us a unique opportunity here to serve the common good, which is part of our mission, which is in our statute. We're a quasi-public state instrumentality, meaning that we get some of the benefits of being state-related, but we don't have some of those things that may not necessarily be benefits, like not being a state employee. Speaking of benefits, I don't get state benefits, but I also am not subject to the merit and the procurement rules that can kind of sometimes grind things to a halt. So we can be entrepreneurial and look to do things that are innovative, specifically in the area of patient engagement. This is the key where we could really help solve or help with bringing down the cost of health care. What I would love to see sometime in the future, given my background in financial services and trying to make things better, what I really would love to see is one day is that we bring down the cost of healthcare so much in our state that it serves as a means to attract new opportunities and jobs to our state and our surrounding area, and that it has helped make the healthcare better for both employers as well as for our citizens and those that are served by our healthcare system. And I think we do that best by patient engagement and developing those tools, developing transparency are going to be those things that I think are going to be very much in the forefront for our organization over the next, 6 to 8 months in terms of being able to get some robust tools out there to help promote engagement. So I look forward to talking in detail about those items.
Again, in the sequence, we now have Janelle Burns, who is actually providing health services.
So I'm Janelle Burns. I'm the Corporate Privacy and Security Officer for Baptist Memorial Healthcare based in Memphis, Tennessee. We have 14 hospitals and approximately 150 physician practices spanning Mississippi, Tennessee, and Arkansas. So we are definitely a covered entities, and I too am a patient, so I appreciate the patient point of view. And so when I'm helping to work on policies and procedures, I always try to keep that in mind of what would our patient want, what would our patient understand about this. To Deb's point yesterday about data mapping, I think some of the discussions we've had this morning about notice of privacy practices, even though as an organization we are an organized healthcare arrangement and we have a joint notice of privacy practice, and I feel like it's very thorough, and I've often gotten complaints from administration that it's too long. At the same time, I can tell you that any patient who even takes the time to read every word of our notice of privacy practices will not know every place that their information goes. We participate in a lot of registries. To a certain degree, we're compelled to participate in those because for certain designations, for certain quality measurements, we are required to participate in registries, and they do collect a lot of information about our patients. So a lot of my time is actually spent when we're negotiating business associate agreements with those registries, really questioning them about the data elements they're collecting, and trying to make sure with security assessments and security questionnaires that they at least have a basic understanding and are going to be able to protect the data once they have it in hand, because ICS really is a gatekeeper to helping protect our patients' data.
And last but certainly not least, we have a legal health law scholar and presenting and prepping us up for the discussion on the limits by introducing that perspective. Please.
Thank you. I'm Barbara Evans. I'm a law professor. Before I fell from grace and became a lawyer, I was an electrical engineer, so I've always been interested in data systems, and that puts you in the privacy realm nowadays, because that's such an important issue. I strongly am inclined to the idea that people should have access to their own health data, and yet I have difficulty in my mind finding what is the legal basis of that right, what is the moral basis. We're in this era where we have just clouds of data generated about us, and we feel we have a strong interest in it. In the past, we had clouds of data about us. It was called gossip, and there's no norm that people who gossip about you have to tell you what they said. And in the same way, we live in this age of ubiquitous cameras, and I don't expect everyone who captures me in the frame of a photograph to let me have a copy of it. And yet, despite this, I think many of us, I'd be interested in a show of hands, how many of you feel that you should be able to access health data about yourself? Interesting. Is anyone against it? No. No, and the question is, how do we implement it? Under HIPAA, many people have problems with HIPAA, but one thing it did well was establish, through a federal regulation, a right of access to data. I was so happy recently when that was extended to our clinical laboratory data, and have explored how broad is that right for genomic data. One of our big problems now is we have this large amount of data that is outside the HIPAA space, and how do we get an equivalent right for that? I think that's an important issue of our time. The other thing is, I do quite a bit of research on just the layer after layer of limitations on our right to data, and often it's driven by well-intentioned policies that are trying to protect us. There are IRBs that are going to decide whether it's ethical to let us have return of our own test results from a research setting. There are very well-intentioned regulators that are trying to keep us from getting information that we might misuse or misunderstand or that might not be accurate. And then there are medical practice regulators that limit how information is disseminated. I think the First Amendment is an important tool to break down those barriers in some contexts, but it only protects against governmentally imposed limitations and not the privately imposed. So it's a very difficult right to implement. I think it's one we all are very sympathetic that there should be such a right. And I'll be happy in Q&A to discuss more, but just wanted to give you an overview. I don't provide any healthcare services. I sit in an ivory tower and look at them.
Okay, so let me start with the first moderator, a prepared question. And, the last major legislation that affects limits to access was high tech, and that's 6 years ago now or more, and it had certain provisions related to portals and the meaningful use regulations. It helped maybe a little bit, but again, as we heard and as we all know, it didn't go very far. Previous to that, we have HIPAA, which is now 20 years old. And HIPAA introduced this, when it was modified in 2002, introduced this exemption called TPO, Treatment, Payment, and Operations, which is where the institution does not require consent in order to share that data. And what that effectively created is a system where 99.9% of the data flows out of the institution or amongst institution without consent, and actually, even though it's required by law, without an accounting even or an audit on the part of the person or anybody else. We heard yesterday that maybe they're going to start auditing these procedures at the OCR level, at the institutional level, but there's actually no audit or transparency. So when you have just all but the paper faxes leaving the institution through electronic means now 20 years later on the TPO, it's obvious that there aren't any significant incentives for the vendors or the data holders to provide data in a way that Hugo and Mark and the HIE, in a broad sense, is going to be able to benefit from, whether it's for care coordination or economically by shopping around or whatever. So let me start with trying to get people's impressions, since we have this precision medicine initiative and the 21st Century Cures Act. It looks like within the next 6 to 9 months there will be some funding, bipartisan support, probably a lot of it through NIH, and then some changes as a result of various frustrations in 21st Century Cures. What needs to be done, what can be done in order to improve the situation with respect to patient access as part of this where we are today? Anybody?
Yeah, in terms of the currency that we have, I mean, some folks would refer to it as data. I refer to it as faith. I mean, it's the same kind of value that provides our currency with its intrinsic value, right? We don't have anything if we don't have the faith of the patients that the information is safe, secure, and it's going to be used to serve their needs and that of their families when it's needed. So protecting that information is paramount. That's like the first cause of any organization that has responsibility for personal private health information. And with that, providing a line of sight for that patient to understand who has accessed their information, as well as who, when they get information into their patient catalog, be it a result or whatever, transcription summary, is I think key to building that faith and building that currency, right, in terms of the value of our network. And I think it's incumbent upon organizations like mine to provide those types of tools. Now, the challenge is that we've got a 21st century way of sharing information with providers because the population is manageable. I have a field team that goes out and actually validates the identity of these folks, validates the license, that meets regularly with the providers and their staff to ensure that they are, clinicians that are acting on behalf within their medical license. To do that with 100,000 patients or 900,000 or 2.1 million patients, well, we need a 21st century tool for that. And part of our challenge is not so much that the technology is not available. We all know it's there, right? We access our credit bureau information. But putting it in a way that we can, just support it from a financial standpoint. People have to pay for this type of a tool, and it's one of our challenges because even though we're a nonprofit organization, we're in the same business as everybody else in this room and outside this room. We're all in the business of making money and staying in business. Being a self-sustaining HIE, which is a rarity these days, we've been self-sustaining for 4 years, and we want to stay that way. We cannot offer tools unless we have a way to pay for it. So with this, I think there are opportunities. I think we're close to cracking the code on it. But I think that's one of the biggest barriers for organizations like ours is not so much the technology, but how do you pay for it? How do you make it so that it's going to be affordable, going to be attractive for folks to be able to leverage the tools that are going to give them the access, and it's going to be something that's valuable. PHRs are free, but I mean, we've seen what the adoption of PHRs has been. It's been challenged, and we want to make it more than just, a place where you could self-enter information. That's not really building transparency.
Legislation opportunities, anybody?
I think there are legislation opportunities, although along what Randy said, one of our huge issues is cost. We historically in the Memphis metro area have participated in a regional health information exchange. Each of our 3 states has their own statewide health information exchange. We recently finished implementing a electronic medical record system with a patient portal. And so all of this is very costly. Some of the state health information exchanges at this point don't cost us anything. One state health information exchange is actually quite expensive. And so it is, I guess the opportunity that I would see is that if there would be a more coordinated effort, I feel like there's been this federal push to move us to health information exchange, but we don't necessarily have a very good coordinated effort. So as providers with a lot of data, we get caught in the middle trying to make sure that we're complying with meaningful use, that we're complying with HIPAA, that we're respecting our patients and trying to do what's best for them in terms of getting their data to the other practitioners that need it. But it gets extremely expensive trying to meet everyone's needs and fit all the requirements that different groups have placed upon us. So if from a legislative standpoint there could be greater organization, that would help us a lot.
Sure. I think to the point about PHR adoption, yeah, it's really been dismal. But as I was actually at Health Data Palooza yesterday, and this comment came up, and it's a case of, well, you sign into a PHR and there's nothing there, and so why do you go back? And you're going to sit there and key in data that you've got maybe on a fax or whatever from some other source. We as consumers are sort of expecting, I think we have an expectation that may be a complete fallacy, that we go to a doctor and we expect them to be able to exchange information elsewhere, and it doesn't really happen. And one of the key things that I took away from the Palooza of the last couple of days was this comment from Manish Chopra, which says, everything, you look at all the changes that have been going on at the policy level, at the payments level, around value-based payments and so forth, it's all pointing towards the patient. And so I think we're reaching this point where, in a few years, I certainly believe that there's going to be a tipping point when you take all the wearables data and all of these other sources for us. I know, I see you're wearing your Fitbit, I've got mine in my pocket, I've got my posture monitor, and your cell phone's in your pocket. It's all these data sources. Mm-hmm. And it's not going to be long before the patient is going to have, or the consumer is going to have, far more information than any individual provider. And at that point, there's then some incentive for the providers to then want the patient, the consumer, to participate fully in data exchange. Now, that doesn't mean that the patient has to manage all of that. They can go to a service that they trust to provide that. It can be somewhere that's just a routing to pull data from all the different places. It doesn't have to be a store. So we are going to see a change, I think, in a very few years. And that may ultimately simplify things, because then we get back to the primary transactions between the patient and the provider, which is where the trust is.
So is your point that legislation is out of scope for this?
I don't think it's necessarily out of scope. I think there are things that we need to do, and there have been some good things done. You look at legislation around your genome, that you cannot be discriminated against based on the content of your genome. That's the sort of places where I think government can take a stand. There's lots of data about us. Let's make sure it's not used against us.
I agree that a lot of positive things are happening and have happened, but this question that's been raised about financial sustainability and cost and how do we get the infrastructure developed, I think it would be very helpful if we would, in a four-square way, have legislation that recognizes this is an infrastructure development problem, as our nation has encountered in the 1930s with its power grids, railroads in the 1870s. There are certain problems that infrastructure poses on how do you finance them, and I think this is a good example. A lot of the benefit of health exchange and patient access is this sort of intangible improvement in health. It's a public or non-market good. That makes it very hard to say it's worth this and we can charge this rate for it and monetize it. And yet infrastructure can be developed, and I think we're missing an opportunity if our legislators don't look very carefully at what we could learn from the lessons of other similarly skilled infrastructures that we had to build.
Anything else on this? Mark, legislative question?
Well, I would hope that there would be. What do I know about legislation? I don't. But I would hope that there would be some sort of legislation that would say patients have the right, at least, to have some level of access to information generated inside their own bodies. I mean, this is. I don't have much expectation in terms of privacy. I don't really. It's not something that concerns me as much as access and control over my health information. So it's that kind of old call about nothing about me without me. Doctors rely on information and on data to make important healthcare decisions every single day of their jobs, and yet patients, particularly people living with chronic conditions, are expected to make decisions without the benefit of data. So it's how does that make any sense? We must change that, and I would hope that legislation could fix it. I've been trying to play nice for a long time, and can we just get it done?
So it's basically a patient rights issue, legislation.
Right. I absolutely believe that.
Okay. So here's the second question that we came up with. And this one has to do with the incentives, economic or otherwise, around the limits to patient access. In particular, we've heard a lot about accountable care organizations, ACOs. There's now a very rapid ramp up, I think. I'm not an expert in the Medicare payment rules, but I think it's fair to say that there's now acceleration of this goal of paying physicians or paying for health services as part of networks, as part of bundles of patients within networks. And this actually interacts with limits to access for information because from various perspectives, whether it's you have this bit of conflict between the patient's right to choose where they go for care, which is built into Medicare fundamentally, and for the most part is still there, and I'm not sure if people are trying to change it. I don't get the feeling that this ability of a patient to choose any hospital or any doctor is fundamentally being considered to be removed. And on the other hand, as you try to pay the providers on the basis of the populations that they manage rather than any individual patient, they come back and say, but you're attributing patients that I have no control over. I don't have access to the information when the patient chooses to go outside of my specific named network. And so this creates a tremendous tension around what is maybe the central idea behind high tech and the Affordable Care Act. In other words, it has a direct effect potentially on an incentive to limit patient access, not because providing the access is expensive as an infrastructure issue, which we just talked about in the first question, but because the access has bottom line effects if the patient seeks more expensive care or care that the responsible patient group feels is unwarranted. Anybody?
Well, there's this belief sometimes that if patients have access to their information, that it will have bad consequences, that they'll get unnecessary care, extra care. Under our First Amendment, there's case after case after case that the fact that people will do foolish things if you give them information is no reason to suppress communication. What you do, you regulate the foolish thing. If patients are going to get unnecessary surgeries based on access to their data, you regulate the doctors who do the unnecessary surgery. You don't keep the patients in the dark. So I don't buy this information will have bad consequences argument. It's unconstitutional and it's wrong.
Bravo. But my point was that it has bad economic consequences to the value, to the practice that is in effect going to be dinged for that decision.
Let me have a bite at this one. Again, I go back to the point that everything is pointed towards the patient. Now, look, CMS, for example, and I'm not speaking for CMS. I'm no expert in that area, but the Secretary announced that 30%, I think it is, of payments are going to be value-based payments by I think next year, and 50% by 2017. That's effectively 50%. That's about $300 billion worth of payments in this economy at current day's prices that are going to be value-based. The other thing, I say that the recession has done more to make a change than anything, in that what happened, employers use the term buying down benefits. They try to keep your premiums the same, but you took more responsibility. So we've created this scenario where now the patient has more financial responsibility. And I can tell you from other startups that I've worked with where they would present information to patients, to consumers in simple terms of saying, do you see that you could get this same medication from another pharmacy down the road and save yourselves $200 a year? Do you want to do that, yes or no? And most people would go yes, right? Because when we're armed with information that we can make an informed decision, in many cases we do make a good informed decision. But at the moment, we work on the basis of making a guess because we do not have information as patients.
And I think part of it, what we talked about yesterday, is a fundamental right, is the right of the patient to choose not to participate. And there is some stress there between the patient who chooses not to be engaged and not to actively participate, and yet the provider is financially punished if they are not able to get them to participate and lower their A1C values or get their cholesterol under control. So as Mark is saying, everything keeps moving us back to the patient. The question becomes, is the provider the one whose payments should be based on participation, or does the patient have an obligation to play an increased role in that? But yet it's the same basic right of the patient to choose not to be engaged. As I said, we've implemented an electronic health system that's consistent across all of our hospitals and our physician practices, and it has a really cool patient portal that comes with it. And most patients, once we can get them to use the patient portal, like it. But we actually have a fair number of patients who just simply don't want to sign up for it. And so we spend a fair amount of time trying to convince the patients to sign up for it, to engage them further than what they are. And so we have a great variance of patients. We have, Hugo, who wants more than a portal. He actually wants raw data. And then on this side, I have patients who, it's just a bunch of numbers. Well, I'll just do whatever my doctor suggests. I'm good with that. And it's hard when you're trying to, as a country, figure out the ways to make to make the most economical decisions while providing the best care possible, and giving your patients their basic right of choice.
If I could, Hugo, I want to just follow up on that for a second with Randy and Janelle. The question, though, with respect to ACO's attribution and and even from the perspective of engagement, has to do with interoperability, has to do with access to data. In other words, your hospital is at risk for care that's given outside of your hospital if the patient walks to somewhere else. You then might need an HIE to have access to it, or you might need access to that patient portal that we've been talking about, not your own. And so relative to this change to ACOs, how, in other words, can you look at it from the point of view of another group, not yours, in this environment where 50% of the value might come? That's kind of what the question's about.
I mean, I have a standing meeting every week where we talk about health information exchange and how we get data to other providers that are outside of our group, and how we can receive information from other providers. So it's a huge issue of trying to make that work. We participate in direct, and I think what probably gets lost by most people is the level of detail and the amount of organization that goes into making any sort of communication with other systems. For us, it's an issue of patient matching. So currently we're receiving, we'll say 100, that's an estimate, of secure message or direct messages a week where we do not have sufficient information in those messages to match it to the patients in our MPI. So that level of detail, it's not just the technical issues that come into play, it's do we even have the information to know that this patient matches with this patient and they're the same person? Because as you can imagine, there are a lot of people with the same names out there in the world, and amazingly even same names and same dates of birth. So we have to have other identifiers, and a lot of it, we spend a lot of time just trying to work through the practical aspects.
I have to leap in on that because that's one of my hot buttons. That's typical of the industry focus where they're trying to do everything about the patient without the patient. And if the patient was actually involved in some of those transactions, I say Google solved this problem years ago of having multiple identities spread across an industry or across the world. You'd go to a site and say that's me, and you go to another site and say that's me, and they can then connect the two. But the industry is trying to do all this matching without involving the one person it's about.
Okay, Hugo, from perspective, you get the last word, and then please questions.
Okay, so I'm sort of the libertarian in me says, let me take responsibility for my health. It is our responsibility to care for ourselves in every aspect of our lives, whether it's in our careers, our education, we're autonomous agents, self-determining people, and why should not that extend to healthcare? And so to that point, and other patient advocates in the room will probably beat me up once we get outside, but I do think that is not fair to hold somebody else accountable for my actions. At the same time, I think it's important to mention that we are a society that is tolerant to people doing harm to ourselves. We tolerate excessive smoking. We tolerate, I suppose, drinking, and we tolerate rock climbing, which I find very dangerous. I wouldn't do that myself. So, and many other dangerous behaviors. So, how can my doctor be responsible for some of my behaviors that may be considered, might even extend to some of the things that I do, that perhaps I don't exercise enough. I eat meat. Wow. So some of these things may be deemed to be dangerous behaviors. So all I'm saying is that what's important to me is to take responsibility for myself and take responsibility for my health, and that is all I'm asking for.
Please, questions from the audience?
I'm Deborah Crand. I'm a health IT attorney. Been working in the healthcare industry for several decades, and let me try to narrow down everything that's flying through my head right now. I know that the federal agencies really look at, in controlling health costs, look at those segments of the population that are costing our healthcare system the most. A lot of those populations involve Medicaid patients who have extreme chronic diseases, and basically people that are so sick, or like my parents who are Medicare and at the stage where they can't take control of their personal health information, and my father's a physician. So I think that as people in this audience who are knowledgeable, who have certain skill sets to take our data, look at it, consult with the appropriate people to utilize that data in the best way we can to improve our health. There are many in our society who, just don't have the capability. They're concerned about getting better. They're concerned about, just getting through day-to-day life, and their data is important. They also need to understand that they're very vulnerable to their data, if it's not kept secure and private, that they're very vulnerable to the ramifications of that. What our speaker yesterday, Alex Pentland, mentioned was, I think it was him who said he liked the idea of having an agent to manage health care. And maybe that's a concept we could bring in for those who are, as you were saying, don't really care about accessing their data. I don't know. I'm just throwing these thoughts out because I had a flood of thoughts, listening to this.
And we do have a provision that allows for proxy access. So a patient can designate a proxy. So if it's an older patient, they might choose one of their children, and they can have access to the portal too. So.
And I think you raised a really important point that not everyone wants access to his or her own data, and even there's quite a body of data that says even within the course of one person's life, one's appetite to have access to one's data and control changes. The sicker you get, you may want more help with decisions, and I don't want it to get lost. Nothing we're saying would force people to take their data. We just want those who do want to get it to have the right. But you raise a very important point. It should only be people having the right, not the duty to take stewardship of their data. Right.
Bill Yasnoff, Health IT Consultant. Hugo, I had a specific question for you, and I may have missed this in your introduction. The data that comes from your device belongs to the company. You don't have access to it, but they do send it to your doctor. Is that right?
The doctor has access to reports online. The data is not.
The original data is not available,
right, so,
even to your doctor.
Right. It's a cured vision or look into the data.
So my question is, the summary data that goes to your doctor, can you access that data?
Yes, in usually in not in electronic format. It's a report. If you're lucky, you can get it as a PDF. But if you bring a USB port, as I usually do, they won't allow to plug a USB port into the device, and because for fear of contamination. Right. And the concern also is that the reports usually are not, the data is not built in, it doesn't flow into the EHR. Usually what they do is that they scan a copy of the report and put it in the medical record.
So your doctor gets like a fax or a PDF, and the actual data can't be extracted and even used in the EHR.
There are some ways, there are some companies that provide that service, that connectivity,
Sure.
2 or 3 different vendors. But it's not something that, it's not an easy process. And in fact, the clinic I go to, the nurse chooses not to use it because it's too laborious.
So I don't see someone else wanting to ask a question, so I'm going to ask one more. So when you got the device, you undoubtedly signed a consent, certainly to the procedure. Do you recall, or was there anything in that consent about information and what was going to happen to it and the fact you weren't going to be able to get it or anything like that?
Right. That's a really good question. I don't believe there was a consent given to the data collection specifically. But it's something you sign up for, and you agree, with your clinician, with the provider, to be remotely monitored.
Go ahead, please. Another question.
Hi, good morning. My name is Joanne Adams. I'm a privacy officer for a community health center here in the district. To Mr. Campus's point, you say that the device manufacturer is a business associate of your physician. As a business associate, and lawyers can correct me if I'm wrong, they've now become subject to HIPAA, so you have a right of access. As well as if your physician has an EMR, HITECH says that they need to provide an electronic version of your medical records to you if you so request it. So to the other point, I think Ms. Burns mentioned, as a provider organization, we want our patients to have their information. Mm-hmm. We feel it's very important for them to have it so that they can be involved in their care. And like her, we are figuring out all kinds of ways to get them to our portal. We have an EMR. We've had it since 2009. We think it's a great idea for patients to access the portal to get their lab results and so on, but we can't get them to sign on. So
actually, if I could say one thing that comes to mind with the last 2 questions is the issue that we do have a lot of issues with vendors. As providers, we spend a lot of our time and effort dependent upon the vendors who are providing the solutions to us. And that's probably the one area where we have a lot of regulated people, but they're not regulated. And so we have a lot of security issues because they tend to like to build their software on platforms that are old and are no longer supported. We have security patching issues with those. That also leads to the ability of the patient to be able to get access to the data. But that's the one group that really isn't regulated.
On the point of access, I think part of the complicating factor is, especially for those folks that are frequent users or heavy travelers of the medical ecosystem, they'll get a portal at their specialist, they'll get a portal at their PCP, and then they take their child to the pediatrician and they've got a portal there. And, guys, look, we all know we are not short of login IDs and passwords, right? So I think that is one of the inherent barriers to adoption on the portal side. And at the same time, it's very cost and effective for all these organizations to be setting up their individual portals. And that's, where I would say is it's like our organization, or organizations like ours, a statewide, robust statewide or regional HIE, where all the information's coming to, why not just have one portal? And this is where, Adrian, maybe we do get back to the legislative question. It's interesting in the NPRM, for Meaningful Use Stage 3, I didn't really notice a point where HIE was referred to as a noun, but it was referred to frequently as a verb. And there's more that could be done to help drive interest and support for organizations where all the information is coming to. I think you'd have more success with patient engagement and having, if you have like a single portal, folks had to go one place to get all their information, and it'd be less expensive for the ecosystem.
Well, I actually discovered yesterday the multiple portal problem is actually called hyperportalosis. I just haven't worked out what the CPT code is for that. But I think the push in the industry, and certainly the push, I think, from the policymakers at the ONC is to really think more around APIs, because you never really get to one portal. it's an example. I have this strange accent, so if I end up in the UK and end up in hospital over there, is that data going to get routed back to that one portal in, you know, Delaware or Maryland where I live? So again, everything is pointing back to the patient, and you know, I've certainly voiced my concerns about things like view, download, or transmit, and saying, you know, could we change the policy to say force 2 out of the 3, because then we get away from view being sufficient.
I think that, oh, please.
My name is Han Xiliu. I'm the PhD student here in Georgetown Law. So I guess since I'm a student, I can ask a stupid question. So after hearing your speech, I still get confused whether I can get my medical record from the hospital or doctor as a whole copy, no matter it's in the electronic form or like it's in print. If they refuse to provide, whether I can sue them to get them through the judicial system. So I just, whether I have this legal right, whether it's a state law or a constitutional law. Yeah.
What you would do is you would file a complaint with the Office for Civil Rights, and they would investigate. Unless you have some special state law protections. Some states do give you some additional protections above and beyond what the federal law offers, and you may have some opportunities under a state lawsuit. But generally, you would file a complaint with the Office for Civil Rights.
The other thing you can do out there is in about 4 weeks, there's going to be a big day of action. So if you're on Twitter, check out the hashtag Data Independence Day. There is this push to get people to actually go ask for their records, because I think the comment again at the Palooza was something like 2/3 of hospitals actually attested to the fact, you know, where they'd seen 100,000 patients and not one person actually asked for their records, and that seems, you know, sort of highly suspicious. So there's a real push to get people to go and physically, you know, actively ask.
Tom, last question.
Yeah, this is a question to the whole audience and to the panel. I'm Tom Trezise. I'm a partner with Randy on the Delaware Health Information Network. Has anybody sat down and actually mapped out the 15-year journey that other industries who are ahead of us have evolved through in this process, whether it's finance, telecommunications, whatever? Everybody basically started with, you know, localization, non-electronic, integrated, non-integrated data. Has anybody actually sat down and said, you know, here's a storming and forming stage, here's phase 2 of evolution, phase 3, so that we can take some of those learnings that have evolved from other industries and really sort of say, maybe we could use some of those learnings in this healthcare journey? And I was just wondering, has anybody actually spend time and map that out so we can do knowledge transfer? Good. Can I talk to you? Good.
But healthcare is hugely more complicated than those.
Can I make a statement? Every organization I've ever done, and I've dealt with organizations across 190 countries trying to do an integrated capability across 190 countries, and everyone has said, well, you know, we're special and different. And so I just put it within that context.
And that's actually a great reason to go on a break.